Hi everyone, and welcome to this new webinar Learn with from the Masters in Knee. You know the concept, I think. 1 hour with us, and we will have a talk from our guest, and I will introduce him soon. And then you can ask questions. So feel free to ask questions. I think it's very important to have people for the interactive discussion. So almost 25 minutes, something like that, presentation, and then we can discuss and feel free to ask questions, even if you are a bit shy. This is you can even ask questions anonymously, so it's not a big deal. And I would like to remind you that this session will be available as a replay on the BeeMed platform after this session, so it's always possible to replay this session. And I'm very happy to host and to welcome Professor Bancha Chernchujit. Everyone knows Bancha as Bancha. He's a sort of star from Thailand.
Oh, thank you.
But beside to be a star and a very good friend, he is a great expert, and is very active in APCAS, in ISACOS, and different society. And he will talk about meniscus tonight. He will give us his great experience about from small and easy lesion to the big one. So Bancha, it's a pleasure to have you, and you're on the podium. You have the microphone now, please.
Thank you so much. Thank you, Philip, for the invitation. I'm also excited. And this is my first time to join the BeeMed. Yeah. Thank you, Cecil. She helped me a lot.
And not the last one. I'm sure not the last one.
Thank you so much. So I feel like this is very casual. Yeah. So we can, please feel free to interrupt me on or ask the question. Yeah. Anytime. So today we are talking about complex meniscus injury from repair technique to the allograft transplantation. So thank you, my 3 fellows, for preparing the document. So I think this is the very interesting topic because I love meniscus so much and have bad experience in the past, but now we try to do our best to save the meniscus. Okay. Thank you, Philip and Cecil, for inviting me today. So the meniscus surgery, I think, is very challenging because meniscus tissue is very unique. Comparing to the ligament, you can fail ACL surgery anytime, 2 times, 3 times, you still have spare part. You have allograft, you have opposite side, but meniscus is a very unique tissue. So you have only one chance. So the quite challenging. Healing potential, tear pattern, and fixation techniques is different. So I think it's not easy to make the meniscus heal. So for me, number one is to start with a good position. If you have good position, you can have the good exposure and you can address all the meniscus easier. So for me, I prefer to break the table and drop the leg down. So you drop the leg down, you have a gravity effect. You can have more space, okay, and you can go around the meniscus. Because sometimes when you get in, you have surprise. Oh, there's a ram lesion. If you have this position, you can go to the back and repair the ram. Okay, you can put the X-ray in. Sometimes you need to use X-ray to see your bone, right? And this position is very very good for me. Yeah, so I always do the knee surgery using this position. And another thing is that when you're dealing with the meniscus, meniscus is located in a very narrow space. I think it's more difficult than doing the ACL, PCL reconstruction because you have more room. For the meniscus, it's very narrow. So for me, I think exposure is quite important. So we propose the technique we call magic point release. So you can read my articles in the arthroscopy technique. Very easy. You draw the line from the posterior cortex, okay, of the tibia to adductor tubercle. Another line is you connecting the joint line, right? There's intersection, and you draw the line up about 1.2 centimeters, okay? And then if you touch this magic point, the joint will pop and open up, right? I will show you the video. See that? It's pop. This is the magic point, right? And you can address the meniscus. You have more room to work. Okay. I show you again. So you see, it's sudden pop, and you can do meniscus root repair. You can do radial repair. You can do extrusion meniscus reduction, because sometimes the bucket handle is difficult to reduce. If you have more space, you can reduce the bucket handle also, right? So don't hesitate to release the MCL. So there's many ways to repair the meniscus: outside in, inside out, or inside. Yeah. So for most surgeons do outside in for the anterior meniscus, the inside out for the body, right, or posterior part, and or inside for the posterior, right? And when you're dealing with the medial meniscus, you must be careful, because on the medial side there's a saphenous nerve also. When you tie the knot, don't tie the knot over the saphenous nerve, okay, because the patient will have painful neuroma. Okay. So for the neurovascular safety, we did the publication with Dr. Chaiwat. Yeah. On the medial side, it's quite safe, but when you're dealing with the lateral meniscus, you have to be very careful, especially in the location that very close to the lateral root. Okay, this area is about 1 centimeter from the root. If you're going from the same side, you can damage the vessel. Okay, so very, very careful when you repair the or inside meniscal repair on the lateral side. Okay, so you can coming from the opposite side, that would be safer. So that also the common peroneal nerve on the popliteus hiatus. So there's two structures that you need to be careful on the lateral side. Number one, the vessels. Number two, the nerve. Okay. So repair technique, I will go in details, right, about the techniques. So many times we're dealing with a complex and difficult meniscus tear like this one. So in the past, yeah, we always cut it. This patient is very young. He's 43 years old, has a complex meniscal tear that's combined radial tear with longitudinal tear with horizontal tear. So try your best to save the meniscus, right? This patient, I did the meniscus save for her. Right now, I follow her for 10 years. She's doing very well, right? This is a lateral meniscus repair. So try to save the meniscus, yeah, especially if the patient is still very young. So this patient also have the bad meniscus. When you do meniscectomy, don't cut the whole meniscus. You're just trimming the unstable part and repair the stable, like that. This patient, she has the radial tear with complex. So I just trimming the unstable part and performing the radial part, radial meniscus repair. Okay. So this is my way, right? I try to use a shaver, not basket punch, because when you use basket punch, you always cut it too much. Okay, just use a shaver and try to repair the meniscus. So for the radial meniscus tear, the incidence about 10 to 15%, but I think this is a very challenging, the radial tear. For me, the healing potential of the radial tear is not easy comparing to the longitudinal tear, and sometimes it's coming from the meniscus degeneration, right? So once you have radial tear of the meniscus, it's like you have meniscus root tear. So you loss of hook tension and you progress to have early arthritic change very fast. So radial tear are a bit aggressive. Yeah. If you have radial tear, you should save this meniscus. And sometimes you can miss it. Okay. Only 37% of radial tear will accurately detect by the MRI, right? So that means around 60% of the accuracy, right? For the radial tear, the overall healing is around 60%, and partial heal is about 60%. Yeah. So treatment options: you can do partial meniscectomy or meniscal repair capsular base, or you can use a meniscal base. Okay. So we show you. This is my friend, Dr. Chanakan. He had bad meniscus. Yeah, he has a meniscal radial tear. So I try to save his meniscus. He also have the extrusion of the meniscus. So I reduce the meniscus and extrusion reduction and save his meniscus. Okay. So right now he's doing well, but 2 years later he's come back again with the opposite side. So right now I fix both knees, of him, right? So he's still doing well, So another pitfall is that when you use the allos or implant, be very careful, because this allo sometimes is it not fixed well, or when the patient start to move, the allo can pop out and can be the foreign body in the joint. Okay, very careful, and that can damage the meniscus. So for the radial tear, Dr. Labrat proposed the transtibial fixation repair also. Okay, I think that's good. That can improve the healing potential by make a tibial tunnel, right? So for me, I use the combined transtibial, and also I make a side to side. So that is my current technique for the transtibial meniscus radial tear repair. Okay. So from the meniscocapsular lesion, this is the common situation. The RAM lesion always combined with the ACL. So once you have a RAM lesion, I always looking from the postural from the notch. Okay, but 30-degree scope, the viewing is not so nice. You look at this, the first image, you cannot see very well. That's a blind spot. So you can use 7-degree scope, but there are also the blind spot. For me, I prefer to use the transeptal technique, looking from the opposite side. Okay, and we publish this technique. Because sometimes you did not have 7-degree scope in the operating theater. Okay, so this is my publication. So with Dr. Pinkawat, right? So we make 2 portals on the medial side. I'm looking from the opposite side using the transeptal technique, right? So this is the way we repair the lamb lesion, right? So it's all inside. Okay, you don't need to release. You see that I'm looking from the posterolateral transeptal technique, and we have 2 medial portals. Okay, so from this view you can see very well, and it's like you repair the Bancha. Okay, if you look from this view, it's like you're doing the shoulder surgery, right? Okay, and the healing potential of the meniscus lamb is very good. Okay, so this is another way. Right now I prefer to repair the lamb lesions using 2 bites. Okay, we have 2 medial portal. So if you have 2 bites, you can have the bigger bite. Okay, you can have the very nice robust healing. So that is the meniscus ram lesion looking from the 70 scope. And sometimes you can also repair your ram lesion from the using all inside from the front. Like this, you can use the all inside, okay, from the front. Okay, that also works well. But I recommend that if you do it blind, sometimes it's not your surgery may not so good. So I prefer to, for myself, I prefer to repair it from the back. But sometimes the ram lesion can heal spontaneously, like this patient. He has a torn meniscus, ram lesion at the beginning, but after conservative treatment, the meniscus also can heal, right? So not every ram lesion need to be repaired. Okay. So this example, he's the 37 years old with twist injury and tender at the medial joint line. The patient had the ram lesions. Okay. So this is my way I pat the scope into the medial compartment, use a shaver, and make 2 portals. Okay. So this is my way. I prefer to make 2 bites. Okay. And you can have the bigger bite. So you use the left curve and the right curve. Okay. And then you can have the very strong repair. And after that, ACL reconstruction. For me, I rarely see the ram lesion isolate. It's always combined with the ACL. Okay. So this is a bucket handle on the lateral side. Okay. So for the lateral side, I try not to use the anchor because is mobile. So for me, for the lateral side bucket handle, I prefer to go to the back, like I repair the ram lesion on the medial side. Okay, you see that? And you don't need to have, it will be safe for you because it's on the lateral side. If you put the anchor to the back of the joint, it's a bit risky, right? So this is an example of the bucket handle on the lateral side. The patient have very nice healing of the meniscus. Yeah. So the next meniscus tear is the horizontal cleavage tear. Most of my patient is the middle-aged patients. Yeah, because the horizontal cleavage is always coming with the meniscus cyst. Okay, and sometimes they have no symptoms, and sometimes they have symptoms. Like this patient, they have the meniscal cyst. We did the meniscal cleavage repair, and also I prefer to inject the back into the repair. And you can see from the MRI before and after, right? So before the surgery, you can see the big gap between the meniscus, and after surgery, you see it's completely healed, right? So in my practice, I always using trepanation with wrap around repair together with the BeeMed, and I found the outcome is pretty good. Yeah. Another interesting one is the meniscus root. I think this is the very challenging procedures. Okay, so let's talk about the details. So meniscus root, you can repair it from using the transtibial, or you can use the anchor, right? So we did the study. We found that the meniscus anchor is better in terms of mechanics because your repair site and anchor is close together. You have less bungee effect or telescopic effect. Because if you use the transtibial, your fixation site, I mean the outer cortex and the tarsi is too far, and you may have the elongation, or you may have bungee effect of the suture, right? So this is my publication about the triple loaded anchors. Like this patient have the meniscus root tear with extrusion. Okay. So once we get in, then we release the magic point. Okay, I'm making the raw surface on the medial side. We make a tunnel, and then we pass the anchor into the meniscus, and then performing the meniscus repair. I like to do the Mason Allen's technique, okay, like that. And on the tibial side, we can back up with the button. Yeah, so that is the way we repair our meniscus root. That is the medial side. On the lateral side, it's different. Most of the lateral meniscus root is combined with the ACL injury. Like this patient has torn ACL and have severe pivot shift. So once you have severe pivot shift, thinking about the meniscus root too, right? This patient, we pass the anchors into the tibia, and then we repair the meniscus root, okay, before and after, and then we fix the ACL, okay. So the healing, I think, for the lateral meniscus root is better than the medial side, because the lateral side is rarely extrusion because you have Blisberg and Humphrey that preventing the lateral meniscus extrusion, yeah, comparing to the medial side. So the root repair with SGO is very common in for me, because sometimes the patient come to see you very late, yeah, and you have too much extrusion, you start to have arthritic change. So the SGO may enhance the anatomic meniscus healing and also decrease the load to the meniscus root and stop progression of the medial compartment of the knee, right? So I think now many surgeons did the combined SGO with the meniscus root repair, okay? Like this patient, 65 years old, meniscus root tear with cartilage. This is have the OB2, right? So once the patient have OB2 or 3, I prefer to use the combined SGO with the root repair, okay? And also you have axis deviation, okay? So that is my root repair. Mostly I prefer triple loaded. Yeah, the third one is to reduce the extrusion, okay? And after that, we proceed to do the high tibial osteotomy, yeah. So we collect the axis. So once you do the SGO combined with the root, the SGO will protect your root also, okay? Because the is unload the medial compartment. And I found that the healing after STO is better than root repair alone. So in the patient that have the high BMI or start to have arthritic change, virus more than 5 degrees, okay, and patient have the chronic pain, I think just root repair alone is not work. So you need to combine the root repair with high tibial osteotomy. Otherwise, it will be fail, right? I have some patients that have very high BMI. Even the root heal, but extrusion not come back. So the patient still have pain. So keep in mind when you're dealing with a patient with high BMI more than 30 and axis deviation, okay? Or start to have arthritic change or be 2 or 3. So meniscus extrusion reduction is becoming more and more common, but we look in the literature and also myself, I found that the outcome is unpredictable because most of these patients is coming a bit too late and the outcome is not good. If you did not combine extrusion reduction with the STO, okay, it's good in the patient have trauma, yeah, but in the chronic meniscus tear with started arthritic change and extrusion, the outcome is unpredictable, okay? So root reconstruction is proposed by Dr. Kim. Yeah, I think it's good for the patient have big gap, chronic meniscus tear or failed meniscus repair, okay? So that is the another publication about the meniscus root repair, meniscus root reconstruction. They use the gastrus tendon, yeah, to reconstruct the meniscus root. The good thing is that the meniscus, the gastrus will act like the tissue bridge. So you will have less gap and also it's more reliable because you can tension and fix the gastrus with the screw, okay? So that is the benefit of meniscus root reconstruction, yeah. So I show you a case. This patient have the chronic meniscus tear. So I pass the gastrus into the meniscus, okay, and pull the meniscus gastrus into the tibia. You see that? This is the gastrus that pull the meniscus and it's acting like the soft tissue bridge. So the healing potential should be better comparing to the suture, okay? Because you connect the meniscus to the canal. Yeah, this is my experience. For the bucket handle tear, don't give up because in my experience, bucket handle, the healing potential is very good. Yeah. But the problem is that if the patient come very late, you may have difficulty to reduce the bucket handle, okay? And sometimes there's some scar tissues. So for the medial side, I think we have better outcome on the medial side because you can release the MCL, okay? So after you release the MCL, reduce the bucket handle. The ways to do that after you make the nice raw surface, you start the meniscus repair like you cross the zip. Start from the most anterior posterior first, okay? And repair that way. Okay, and if the patient have deformed meniscus, this is my publication. I use the Mason Allens, yeah, to reshape the meniscus to make it like wedge shape, right? So we repair vertical and horizontal to make it reduce the meniscus to make it good shape, right? Because in chronic meniscus, the shape of meniscus will be different. Yeah, it become round. It's not like the wedge shape. So this is after the bucket handle repair. The patient have good outcome and good range of motion, right? So these patients they have the torn meniscus like that. So in the past I will cut it, but nowadays you know how to save the meniscus, right? So I try my best to save this meniscus, even it looks bad, right? Once you wrap around, okay, and make some definition and inject the BeeMed, okay, we can save his meniscus, right? And it's healed nicely, this patient, okay? So don't give up, try your best. So this patient have ACL injury and double bucket handle, right? It's not common for me. This is I think the third case, right? We have double bucket handle. So for the medial side, after I release the MCL, then I reduce my meniscus using the inside out, okay? We repair the upper part and under surface, Okay, not just, and on the lateral side, I try to reduce the meniscus back. Okay, but it's a bit bad. I try my best to reattach the meniscus to the capsule. Okay, and then ACL reconstruction. So patient have good healing on the ACL and also the medial meniscus, but it fell on the lateral side. Yeah. So this patient is still young. So I thinking about the meniscus transplantation. The indication is that the patient is still young, less than 50. Okay, non-functional meniscus, and alignment is good. Okay, ligament is intact. Okay, no cartilage defect. So I prefer to do the meniscus transplantation. So my contraindication for the meniscus transplantation is the patient have severe cartilage damage. Is like OB4, okay, or the severe arthritic change, BMI more than 35, or inflammatory arthritis like rheumatoid or previous septic arthritis. So there's many ways you can do all soft tissue. You can do bone plug. It's common on the medial side. You can do bone bridge. Okay. So for me, I prefer to do all soft tissue all inside. Right. This is the bone procedure using the bone bridge. Right. It's a bit aggressive surgery. Okay. So for me, I don't like to open the joint because I'm the keyhole doctor. Okay. So from the meta-analysis, they found that there's no clinical significance with all soft tissue or bone fixation. Okay. So about the size of the meniscus, yeah, they found that the size should be matched perfectly or less than 7 to 10% error. Okay. Especially if you use the bone bridge technique. Okay. So MRI is the most accurate. So right now the standard, gold standard for measurement the meniscus is the MRI. Okay. So the same patient that I did the double bucket handle, he come back again. He's only 24, right? So ACL healed nicely. So I did the all inside meniscal transplantation for him. Okay. So we're lucky because in Thailand we have a lot of donate. It's common to donate themselves and the tissue for the patient. So this patient after the surgery, we can save his meniscus. We use all soft tissue and all inside technique, yeah, without anchor. So after surgery, the patient doing well. This is about 6 weeks after the surgery. Okay, and he has a good range of motion and also good function. Okay, so that is the fail lateral bucket handle. Okay, so for the medial side, yeah, it's also very common. This patient have the chronic medial side tear. Here's the previous bucket handle resection. Yeah, he's only 37. So you can see from the MRI and the arthroscopic picture, this is the all inside. I use the meniscal base. Yeah, I did not use an implant. Yeah, and I found that when we using the capsule, like you do inside out, when you tie the meniscus, you can find the meniscal extrusion. Okay, so after I use this technique, we use all inside. We found that the extrusion is less. You can see the image MRI. Yeah, the nice healing of the meniscus to the meniscus, and you can see the meniscus in the tunnel also heal very well. You don't need bone because once you need bone, you need the big tunnel or you need to do open surgery. And you look at the MRI axial cut also very nice. It look like the native meniscus. Yeah. So sometimes we need to combine our meniscus with the STO. Like this patient is my friend. He like playing football. So he's 55 years old, 56 years old. So I need to do the meniscus transplantation. This is all soft tissue technique. Yeah. Together with the STO. Okay. So we repair the meniscus, anterior and posterior root. okay, and then tie the knot. Okay, we start to tie the knot from the back, okay, to the middle and then to the front. After that, we do the high tibia osteotomy. Yeah. Okay, but very careful. You don't cut your tunnel should be higher than your HTO. Okay. So otherwise you can cut the suture from the tunnel, right? So after surgery, we let the patient put the weight on 2 weeks after that and range of motion exercise, right? And the meniscus heal nicely. So I think that's all my experience about the meniscus. So in conclusion, meniscus is a very unique tissue. That's very narrow margin of error. Try to save it. Yeah, we have only one chance to make it good. Don't overuse the anchor, because especially the lateral side, because when your patient start to move or you have the mobile meniscus, your anchor can pop out into the joint. For the medial side, don't hesitate to make a magic point release, because meniscus surgery, you need space. Once you have no space, you cannot make a good job. Okay, meniscectomy, you usually end up with the transplantation. So try not to meniscectomy if the meniscus tissue is good. Okay, for the meniscus root, I prefer to use anchor suture or inside. We call this combo technique. We combine transosseous with anchor, so you can have double fixation. You have the double row fixation of your meniscus. For the ram lesion, I prefer to use transeptal, looking from the lateral side using 30-degree scope and use all inside repair. Okay, I think ram lesion, the healing is very, very good. It's the best. For bucket handle, don't give up. If the medial side is very tight, you can release and you can reduce the meniscus. For me, on the medial side, bucket handle is very good. For the lateral side, it's a bit difficult because we cannot open the lateral joint, and sometimes it's very tight. Yeah. And if the patient is irreparable, meniscus allograft remain the gold standard. Okay. Thank you so much. Please love your meniscus like you love BeeMed. Thank you so much.
Thank you for this amazing conclusion, Bancha.